Good afternoon, everyone. So I would like to update change the program a little bit because our speaker have the urgent matter have to go back early. So we would like to change the second speaker to be first speaker. Okay. So we start lab session now. Good afternoon. We are very pleased to have opportunity again to organize laboratory workshop during the 27 already Bangkok International Symposium on HIV medicine. HIV still causes many health issues, including comorbidities and other complications. People living with HIV can be at increased risk of other infections such as TB or hepatitis or HPV or other STI. Diagnostic assay of HIV comorbidities or co-infection is relevant for early treatment and care. So we are delighted to have our honored speaker here with us today to share information on the topic of enhancing laboratory assays supporting HIV and comorbidities. It's my great pleasure to introduce the first speaker, Professor Emeritus Medicine, Dr. Sawang Saenghirunvattana. He received a Master of Business Administration Executive from Sassin Graduate Institution of Business Administration, and he also received Fellow in Critical Care Medicine in Rush Presbyterian St. Luke Hospital, Chicago, Illinois, and Fellow in Pulmonary Medicine. So he will give us the information about Urine LAM to help diagnosis of TB. So please join me to welcome Dr. Sawang, please.
Good afternoon, Dr. Sivimon, ladies and gentlemen. First of all, I have to thank the committee for inviting me to this great lecture. It's my great honor to be here. My topic today is regarding the use of the urine tuberculosis lipoalaminomannan antigen as a tool for helping diagnosis and follow-up treatment of pulmonary tuberculosis. I have no conflict of interest. In this picture, we have to face with the common X-ray of the pulmonary tuberculosis in everyday practice, like the standard chest X-ray, representing right now is a bilateral upper lobe infiltration. Commonly should be the pulmonary tuberculosis, right? The way to make definite diagnosis is from the sputum examination for the acid-fast stain bacilli, which we can see in this picture as a pink rod bacilli. But a lot of times, the patient could not produce adequate secretion for us, or even they can, the smear may be negative, or even culture also negative. Definite diagnosis should be culture bacteria of the Mycobacterium tuberculosis. But when we could not provide the sputum examination, the differential diagnosis may be non-tuberculous Mycobacterium. Like in those HIV patients or non-HIV patients, and it can be occupational lung diseases or alveolar proteinosis or even lung infection or in rare case of the lung cancer. So when the patient and the physician are not quite sure for the diagnosis, it will be a delay of the diagnosis and the delay of the treatment. So WHO has already recommended to use the urine TB lipoalaminomannan antigen to help make diagnosis of the tuberculosis in HIV patients for several years already, particularly those who are seriously ill or in children, to provide quicker treatment and decrease mortality. The sensitivity of the urine LAM antigen in 2023 in 4 African countries to detect TB in HIV patients vary from 48% to 76%, and specificity from 77% to 98%. Even in non-HIV patients, somehow it's quite difficult for us to make the diagnosis of the tuberculosis. So our objective is to evaluate the benefit of the urine TB LAM antigen in our clinical practice to make diagnosis of the polytuberculosis and follow-up of the clinical response. This is our material and methods. Since the early 2023 till late 2024, 252 patients with the lung infiltration and lung nodules who were suspected of the TB were recruited. Sputum examination for acid-fast bacilli, PCR-TB, culture for TB, quantiferon TB in the blood, and urine TB LAM were sent. Data were analyzed in terms of the sensitivity and specificity of the urine TB LAM. That's our objective. Among cases of TB who got anti-TB drugs, the urine TB LAM antigen will be repeated again after the treatment, and clinical response also were recorded. TB LAM antigen is an immunochromatographic test for the qualitative decision of the lipoalaminomannan antigen of mycobacterium in human urine. Determine TB LAM antigen employ highly purified antibodies specific to the major polysaccharide antigen of the genus Mycobacterium. These antibodies are used for both the capture and the detection tracer. The captured antibodies are adsorbed onto the nitrocellulose membrane of the test strip. The detection antibody is labeled by conjugation to colloidal gold particles. After we drop the urine specimen into the sample pad, the colloidal gold conjugated antibody attached to the LAM antigen and then released by the specimen from the conjugate pad. This immunological complex is then captured by anti-LAM antibody immobilized on the nitrocellulose membranes and made visible due to the presence of the colloidal gold label. A positive result visible purple line indicates that LAM antigen of the mycobacteria is present in the sample at or above the detection limit of the test, whereas the negative result, no visible line, indicate that it is not present or below the detection limit. To ensure assay validity, a control bar is incorporated in the assay device. This picture reveals that at the left-hand side, one can see the visible line, purple line over here, which is positive for the urine strip test, compared to the right-hand side, review invisible line. For the results, all 252 HIV negative patients developed lung infiltration or lung nodules. Aged between 18 to 86, the mean was 49. There were 122 male and 132 female. Bronchoalveolar lavage and transbronchial biopsy were done in 72 cases. 142 patients were diagnosed as tuberculosis, in whom urine TB LAM were positive in 98 cases. The sensitivity was 66%. For 60 cases of pneumonia, all urine TB LAM antigen were not detected. Urine TB LAM antigen were detected among 10 patients with the lung cancer, which could be false positive or co-infection. So the specificity is 89%. This table demonstrates the result of the urine TB LAM antigen versus cases of TB. Among definite case of the 144 cases of tuberculosis, urine TB LAM antigen were detected in 98%. The sensitivity will be 66%. Among those 108 cases of the non-TB, the urine strip test was not detected in 98 cases. The specificity was 89%. If one remember at the first slide, among African countries, the range was 48% to 26%. The specificity was 77% to 98%. So our sensitivity and specificity were in line with the African country. How to improve the sensitivity test of such a low one from the urine? So if we combine the urine TB LAM antigen and quantiferon TB in the blood, the sensitivity will either one positive will be included in the case of positive definite tuberculosis. Then we can increase the sensitivity from 66% to be 91%. The specificity was unchanged. It implied that urine TB LAM should be add-on test to other tests or other clinical symptoms. That's my implication. For the discussion, Mycobacterium tuberculosis has a unique cell wall with multiple lipid-based molecules that create a thick, waxy surface of which a major component of this envelope is lipoaluminomannane. As replicating degrades, LAM circulating in the blood is filtered across the glomerular membrane of the kidney into the urine. Data suggests that LAM concentration in sputum was 500 times higher compared to the serum and 50 times higher compared to the urine. Or in another word, LAM concentration in urine is 10 times higher compared to the serum. Kawasaki in 2019 reviewed that an immunoassay with the cutoff of 15 pg per ml detected all smear positive and 50% smear negative cases. In 2017, Suwan Pimolkul in Thailand reported that urine LAM is helpful in case where the smear is negative, regardless of the HIV infection status. In 2021, Amin reported that among non-HIV patients with smear negative but culture positive, the urine LAM antigen provides very high sensitivity of 98% and specificity of 92%. In our study, we also follow up the treatment response with repeated urine TB LAM antigen. And 95% of the patients' urine TB LAM turned to be negative within 2 weeks post-treatment. This will be the world's first clinical report. Other than the clinical response parameter, normally we use improvement of the symptoms such as coughing, secretion, disappearing of the hemoptysis, difficulty in breathing, or increasing of the body weight, and sputum conversion of the acid-fast stain, and improving of the chest röntgenogram. But these clinical symptoms will take about 3 months. So using of the urine TB LAM can provide faster clinical response parameter. And this is my thinking regarding the using of the urine TB LAM to follow the patient who not comply with the treatment. But unfortunately that in my institute, of those patients still comply with the anti-TB drug, so I have no such opportunity to follow this idea. In conclusion, the sensitivity of the urine TB LAM in our study was 66%, specificity was 89% in our group of the HIV negative patient with TB. However, standard diagnostic method of the TB, such as the smear positive or even culture positive, still be the gold standard. Urine TB LAM antigen should be used as an add-on to the clinical judgment in combination with other tests. Thank you for your attention.
Thank you, Professor Sawang. So, anyone have a question for Dr. Sawang? Yes, please.
Congratulations, Professor. I have two questions.
Two questions.
Yeah. First was, in your study, have you included children who are symptomatic and culture?
I'm sorry. My expertise is adult patient,
only adult.
so
Yeah.
I can quite provide a fast, rapid response that I have no any opportunity to see the pediatric patients, so cannot answer that.
Okay. And you did use Abbott Urine LAM, and have you tried also the Kelleher LAM as well, which has, I think, better sensitivity and specificity profile?
Again, please.
The Kelleher LAM, did you use also as well in the experiments? In your study?
Urine LAM and
The Kelleher LAM.
Kelleher LAM, you
Yeah,
mean? I
yeah.
think it's the same test. Kelleher, yeah, it's the same test.
Okay.
Yeah.
okay.
This is the Kelleher urine LAM.
Okay.
Yeah.
So the Kelleher was
Abroad.
used in the
Yes.
study. Okay. Thank you.
Okay, thank you.
Yeah. So any question?
Thank you very much, Professor, for a nice presentation. So I think this urine LAM test is very promising because apart from chest X-ray and AFB test, we have no test that is fast enough to reach the conclusion whether this
Yeah,
person
you are right.
needs
It's quite
to,
fast.
Yeah,
It
needs
takes only
to-
a few hours.
yeah, to take, or this patient has to take the anti-TB right away or not. So in your experience, maybe I'm not very clear in your study whether you include all of the patient in your cohort is having chest X-ray positive or some has chest X-ray negative. So could you share some
all
results
the
on
patient must have the positive X-ray
chest
abnormal.
X-ray positive? So how about chest X-ray negative? Because some
I-
optimal TB can have chest X-ray negative.
You're right.
Yeah.
Because somehow they develop such as a bone TB, you mean something like that? So we don't include those patients, okay, only in the lungs. Okay. In terms of the negative chest X-ray, but there's still some problem in the lung, like we need to perform the computer scan of the chest. In some case in our study, they develop mediastinal lymphadenopathy, which the simple chest X-ray may be negative, but when we perform the CT scan, the lymph node enlarge, and when we use the intervention endobronchial ultrasound to do the biopsy, it turned to be positive for the TB as well. I don't know whether it answers your question or not.
Yeah. So in case that this is just for asking your maybe your comments or your suggestion whether if we have a chest X-ray negative TB and the TB urine LAM test happens to be the only test that it turns out to be positive and suggests that patient is infected with tuberculosis, would you recommend treating this patient?
We have to find out where is the source of the real infection. First of all, why the patient come to see us. That's the main reason. All right. Normally, if the X-ray normal, I don't think I cannot do that. Anyway, thank you for your question.
Is any more question? So I have one question.
Please,
that
doctor.
This population of your study, have the information or the subject who have TB and test positive is proportion in that they have HIV? How many? You know how many percent is HIV?
All my patients are non-HIV.
Also, this is all non-HIV.
Correct.
Okay, so that's very interesting. Thank you. Is any more question for Dr. Sawang? So if not, thank you very much for your presentation.
Thank you.
Very much.
Thank you.
So we would like to thank you, Dr. Sawang. He has an emergency case, so he has to earlier go back to the hospital to see patients. So, so it's my great pleasure to introduce our next speaker today, Science Chair Professor Anthony Kelleher, Director of Kirby Institute, University of New South Wales, Sydney, Australia. So, Professor Anthony Kelleher, we call Tony. He is a clinician scientist. Currently, he is the director of Kirby Institute at UNSW Sydney. And he is also head of immunovirology and pathogenesis program and principal investigator of the infection, immunology and information team at UNSW Medicine. As a clinical academic at St. Vincent Hospital in Sydney, Professor Tony is responsible for clinical care of patients with HIV infection and autoimmune diseases, as well as oversight of the New South Wales State HIV Reference Laboratory. At the Kirby, he is pursuing a range of treatment and prevention strategy for HIV, COVID-19, and infectious disease that span from the laboratory through clinical trials to implementation side. So Tony will give us information regarding on the various of hepatitis and CMV and toxoplasma. Please join me to welcome Tony.
Thank you, Sassy, for that kind introduction, and it's always a great pleasure to be here at the HIVNAT, the Bangkok Symposium, and to meet again all my colleagues from HIVNAT, which is an extraordinary organisation. So today I was going to give a fairly high-level overview of how to the use of laboratory tests and how to interpret those and how they're used in the clinical management of various infections that cause comorbidity with HIV. And all the infections I'm going to concentrate on today really cause long-term complications. And I'm going to deal with hepatitis C and B, as Sassy just said, and also then deal a little bit with cytomegalovirus, toxoplasmosis, and cryptococcosis. As with the last talk, the discussion will be restricted to mostly to the use and the utility of these tests in adults rather than children, though I will make some reference to those, but I think Adam Bartlett particularly pointed out some of the issues with some of these tests yesterday in his excellent talk. And I really wanted to put these in the context of the complications that are caused, not just about the screening and diagnosis of these infections, but the monitoring of the complications of these infections. So as we know, both hepatitis C and hepatitis B, when they cause chronic infection, can cause long-term complications such as cirrhosis and the hepatocellular carcinoma. CMV, as we know, in late-stage HIV causes a range of inflammatory, destructive infections in the eye, retinitis, colitis, pneumonitis, and a range of CNS phenomena affecting both the cerebrum and the spinal cord. Toxoplasmosis characteristically can cause complications in terms of cerebral abscesses, and Cryptococcus can cause both CNS and pulmonary disease. So, dealing with hepatitis C first, in terms of screening the general population, WHO advises that there should be universal HCV screening where in countries where, or regions where the prevalence is greater than 2%. But this applies to the minority of countries. And so in most places you'd use a much more focused approach, and you'd screen for hepatitis C in much more focused populations, such as people who inject drugs, those who have potentially received or received potentially contaminated blood products, those on hemodialysis, those with otherwise unexplained acute or chronic liver dysfunction, and then those suffering from a range of mostly relatively rare conditions. But we need to think about hepatitis C as a cause of an inflammatory arthritis, also as a cause of false positive rheumatoid factor in the laboratory. Sjogren's syndrome is a very common autoimmune condition that causes a range of clinical manifestations, but particularly sicker symptoms, which are manifest with dry eyes and dry mouth through the destruction of salivary glands and lacrimal glands. That can be, but is not usually caused by hepatitis C. Hepatitis C should be screened when someone presents with various forms of glomerulonephritis, such as membranoproliferative. It should be thought about when people present with ITP and mixed cryoglobulinemia, and then a range of rare skin conditions such as porphyria cutanea, lichen planus, and necrolytic acral erythema. And the screening is done using serology. The diagnosis of hepatitis C, it also depends on serology, and characteristically we use tests that give us a readout of the antibody to envelope and or the core protein of hepatitis C. The issue with serological tests in hepatitis C is they can be a very long window period, and it can take weeks for people to seroconvert, even when they have symptomatic acute hepatitis C. And so this is problematic when you're trying to diagnose new or acute infection using serology alone. And if you get a positive antibody test or equivocal test, there should be reflex testing for the virus. And I think if you've got a high level of suspicion that someone is undergoing primary infection, you should, again, try and test for the virus directly. So there's a number of ways of doing that, and one of the ways that has become available more recently is to test directly for the core antigen of hepatitis C. And this is a viable alternative to more expensive molecular testing for HIV RNA. And it's often positive in chronic and ongoing hepatitis C infection, where most of the studies have been done. This has been assessed in a relatively limited fashion during acute infection. This test has good sensitivity and specificity. On the Abbott platform, the sensitivity is about 93%, and higher if the hepatitis C RNA is greater than 3,000 international units per mil. And the ortho test, sorry about the typos there, which is an ELISA, has a quoted sensitivity of about 99%. And both tests are highly specific. There are other tests on the market, but they tend to perform less well. The alternative or the additional testing to the serological approach is molecular approaches to detect HCV RNA directly. This is very sensitive, but it's more expensive, and this limits the use of HCV RNA testing in resource-limited settings. Just a couple of notes on the use of serology for the diagnosis and screening of hepatitis C. So as I've just said, there is a long window period for seroconversion, and so if you've got a high index suspicion for infection after a high risk exposure, then you need to do follow-up testing for a negative antibody test. And that window period is likely to be longer, or in fact generate false negatives if people are highly immunocompromised, such as those who present with late-stage HIV or have late-stage renal failure. And the other thing to note about positive serology is it doesn't reflect disease activity or even the presence of infection. The natural history of hepatitis C is that after primary infection, some people clear that naturally, and you'll remain antibody positive whether you clear hepatitis C infection or not. And so to really understand the disease activity and whether someone has naturally cleared the infection or not, you need again to measure the virus directly, and so you need to reflex test either with testing the antigen or the RNA directly. But again, there is limited access to RNA testing in certain situations. If you've got the resources, the way to cut that window period down and to get the diagnosis straight away is to go straight to qualitative RNA testing, particularly of those with symptomatic acute illness, because that will give you a definitive answer. And I'll come back to the relative merits of qualitative and quantitative RNA testing in hepatitis C. The other thing to remember is that the antibody test remains positive after treatment with the direct-acting antivirals. And so people will generally remain antibody positive for life, but there are now observations that if you follow people for long enough, the antibody levels do decrease over time after effective DAA therapy and clearance. And so if you're using serology to understand particularly the epidemiology of the disease, you may get false negatives in people that have cleared the disease with DAAs many years previously. And so if you're defining your population efficacy of an intervention with DAAs as being RNA negative but antibody positive, that may be, it may actually be an underestimation of the efficacy. But more work needs to be done in that area because we haven't followed people for long periods of time after DAA therapy. There is also the possibility of false positives. Remember, neonates will be who are born to HCV positive mothers will be maybe falsely positive due to maternal antibodies, and so the serology is best determined 18 months after birth. And false positives may occur in those receiving blood products, but particularly pooled immunoglobulins such as IVIG or SCIG, particularly where those donors have been paid for their donation. In terms of molecular testing that, as I said, complements the serological testing, it's much more expensive. And the test is often not subsidised, and therefore this limits access in target populations. There are two types of RNA tests. There's the qualitative test and the quantitative test. And if you just want to know whether someone has active infection, the qualitative test is sufficient. And it has a very low limit of detection of less than 10 international units. And so it is very effective at picking up infection, and its use is to determine whether someone has naturally cleared infection or not. The quantitative tests have a large dynamic range and again give a readout in international units per mil. And it's really used to monitor therapy. And so ideally it's done before starting a therapeutic intervention and then after completing or during the treatment to assess the response to treatment. And in fact, it defines response to therapy, which is usually quoted as a sustained virological response, that is, sustained negative HCV RNA following therapy. It's not needed to be done outside someone who's receiving therapy because it has of itself no prognostic value as to whether that person is going to progress to something like cirrhosis or hepatocellular carcinoma. Genotyping and resistance testing has a really limited role in hepatitis C. It clearly has utility if you want to understand the epidemiology of the infection and for surveillance purposes. And if you want to understand whether someone has been reinfected or not. So the antibody response is not protective. So just because you've generated an antibody response and or a T-cell response, people can get reinfected and people do get reinfected. And so if you want, the genotype or sequencing of the virus may help you prove definitively that an infection is reinfection. But most DAA regimes are now pan-genotypic and also can overcome any resistance mutations, and so we don't routinely offer either genotype or resistance testing in a clinical setting, and its utility is mostly understanding epidemiology. Hepatitis C, as I said, has long-term outcomes, and chronic infection needs to be monitored. And it needs to be monitored particularly by clinical assessment, looking for outcomes of ongoing liver damage and how they manifest clinically. And this clinical assessment, which is done by history and examination, is supplemented by a range of laboratory monitoring, which includes monitoring ongoing liver damage or flares of hepatitis and indicators of disease progression. So measuring ALT and AST is the crux of this. The measurement of bilirubin is more likely to be raised in decompensated liver failure. And alkaline phosphatase and gamma-GT has a relatively limited role in the monitoring of people with hepatitis C, chronic infection. As the infection progresses, the liver function can be compromised, and this can be easily assessed using coagulation tests, particularly the prothrombin time, which will be prolonged, the measurement of albumin, which will be depleted, and this is often compensated by an increase in gamma globulins, and this increase is polyclonal. And then one of the clinical complications is portal hypertension and splenomegaly, and this can be reflected by thrombocytopenia on routine testing. As I said, reinfection can occur, and so in those that clear infection but remain at risk of further infection, particularly through intravenous drug use, those people need to be monitored for reinfection. So in terms of assessing the complications of chronic infection, these people need to be followed up regularly. They need regular clinical assessment, and the clinical assessment is very important, and at least as important as the laboratory tests that you do to monitor cirrhosis, which is a long-term complication of progressive hepatitis C infection. And these can be, the likelihood of cirrhosis can be assessed through a range of clinical scores or algorithms, such as the Bonaccini or Locke scores. And these are algorithms that depend on both clinical assessment and clinical manifestations, but also the severity of some of those lab parameters that I've just outlined, and you plug those in to these algorithms and you get a likelihood of cirrhosis. The Child-Pugh classification is similarly dependent on clinical observation and standard laboratory tests, and again, plugging the observations into that algorithm will give you the a measure of the severity, likely severity of the cirrhosis within that person. Something that's really revolutionized the assessment of cirrhosis is the development of ultrasound-based elastography. It's often called a FibroScan. This is very easy to do. The operators can be trained relatively easily. The machines are portable. They can be used in an outpatient clinic, and they work by putting ultrasound pulses through the liver and measuring the waves that return from those ultrasound pulses, and that gives a measure of the liver stiffness, and that relates to the degree of liver fibrosis and therefore the degree of cirrhosis. So this is a very non-invasive. There are no complications from having a FibroScan. It's non-invasive. It can be done in outpatient settings very easily, and you can use that to measure whether someone's fibrosis is progressing as part of natural history or actually regressing as after the treatment of cirrhosis from hepatitis C with the DAAs, because you can get reversal of cirrhosis after clearance of hepatitis C, or some reversal of it. And so, and this is much simpler and much less invasive than how we used to do this, which was liver biopsy, which had a significant rate of complications, and involved putting a relatively large core biopsy needle into the liver. And obviously, if you've got a coagulopathy and thrombocytopenia, that's far more difficult to do than in someone that's relatively healthy. So the FibroScan has really revolutionized the way we monitor the progression of people with hepatitis C. And as I said, it's portable and easy to do, and has high acceptability both with the users of the machine, but most importantly with the patients. In terms of hepatocellular cancer, probably the best screening test for that is ultrasound as the original form of imaging. Alpha-fetoprotein can be measured in the laboratory, but this is optional and often results in false positives, but can guide you in terms of who might be prioritized for ultrasound. And then characterization of disease stage really follows the sort of standard methodologies for assessing malignancy, but include things like more intensive imaging of the liver and the abdomen by CT or MRI, and biopsy and staging processes to determine therapy. So there are point-of-care tests available for hepatitis C. There are several rapid tests for HCV antibodies, and their performance is comparable to the laboratory immunoassays. They can be run on either venous blood, finger stick blood, serum or plasma, or sometimes oral fluid, and the results are available rapidly. They provide a mechanism of testing for hepatitis C outside traditional clinical settings, and given that the majority of people with hepatitis C are people who inject drugs, often who are very stigmatized and don't engage with traditional health services, the ability to do this in different fora from traditional health service settings with point-of-care tests has distinct advantages. So the point-of-care tests done on whole blood or finger stick have good sensitivity, around 98, 99%, and high specificity. And with all these tests, certain tests perform better than others. In terms of point-of-care tests for HCV RNA, there are various platforms such as the Gene Expert. These again can be done on dried blood spots, which again has its advantage for people who inject drugs who may have difficult venous access. And these can be used both for diagnosis and for monitoring therapy in disseminated models of care. So particularly at the Kirby, we're doing various implementation research projects where we're taking these tests into the community to methadone clinics, and in fact in the back of vans to areas where people shoot up, offering the test and then offering therapy immediately on the receipt of a positive test. So I think point-of-care testing and how it can drive various test and treat processes for hepatitis C is a space where there's a lot happening at the moment. So I'll switch to hepatitis B now. So again, WHO recommends that all adults should be screened at least once in their lifetime, unless there is documentation that they've received a HPV vaccination that is a series that's been completed, and there's serological evidence of immunity. During pregnancy, it should be screened at least once during the first trimester, regardless of vaccination status, and if at risk, they should be tested again. But in a more focused approach to screening is to screen individuals at increased risk of hepatitis B infection. And so that would prioritise people born in countries with hepatitis B prevalence of greater than 2%. The diagnosis of people who have a diagnosis of HIV or hepatitis C, those that have ever injected drugs, men who have sex with men, those with multiple sex partners, sexual partners, or history of recurrent sexually transmitted diseases, those with end-stage kidney disease, particularly those undergoing hemodialysis, household and sexual contacts of Hep B infected persons, and persons who are incarcerated. In terms of Hep B screening, again, we use serology for that, and the serology can tell us whether someone is vaccinated, whether they've been infected and cleared infection, or whether they have chronic infection. And the standard testing includes 3 different tests that measuring the Hep B surface antigen directly, the antibody to that surface antigen, and the antibody to the core protein of hepatitis B. Additional testing in those that are positive for core antibody include the measurement of E antigen and E antibody. So based on the results of these tests, you can get a number of outcomes. So if all those 3 tests, that is surface antigen antibody and core antibody, are negative, then they have no evidence of prior infection and no evidence of vaccination. So if they're hepatitis B surface and antibody positive, then and negative and positive for for the core antigen, but negative for the surface antigen, they have evidence of immunity due to prior infection. If they're surface antibody positive alone with core antibody negative and surface antibody negative, then that tells you that they've been immunised. And then in chronic hepatitis B infection, they have surface antigen positive and they have core antigen positive. In those with core antigen positive in those that are positive for both surface and core antigen, then we measure the E antigen and E antibody, because that gives us an indirect measure of the degree of HBV replication, and also gives us an idea of whether people are likely to progress to those complications such as cirrhosis that I spoke about in hepatitis C. So those who are E antigen positive and E antibody negative are more likely to progress, and so it's an important prognostic marker, and it prioritises those for closer follow-up and also prioritises those who should receive therapy. The aim of therapy is to clear the surface antigen and to hopefully seroconvert to the E antigen, so go from E antigen positive to E antibody positive. As Gail Matthews said yesterday, quantitative assessment of the surface antigen is being increasingly used in clinical trials, but it's not being used routinely in the clinical monitoring of patients, even those receiving therapy. So HPV PCR is for HPV DNA, and it's used in monitoring and in decisions about commencing therapy. And in those without cirrhosis, if they have a HBV DNA of greater than 20,000 international units and are E antigen positive, then those people should be E antibody positive. Those people should be treated. But if they're E antigen positive, that is E antibody negative, then they should be treated at a much lower viral load of greater than 2,000. And all those people with cirrhosis due to hepatitis B should be treated. And what you're looking for is clearance of hepatitis B DNA, and also hopefully clearance of surface antigen and seroconversion of E antigen to E antibody positive. The therapies that are usually used are tenofovir or entecavir, or less commonly now, interferon alpha, and as I said, HBV DNA, excuse the typo, are used to monitor the efficacy. So the goals of therapy are suppression of HBV DNA, and as I said, loss of surface antigen, ideally, and seroconversion to the E antigen. Those serological changes are accompanied by normalization of the serum ALT, warning you that there may be transient flares of ALT, particularly initially during therapy, a decrease in necroinflammatory activity, and a decrease in fibrosis as measured by FibroScan, but that happens much more slowly and over time. So in terms of disease monitoring, again, clinical review is very important, and monitoring of, in terms of both the clinical assessment and the laboratory tests, they're very similar to what I outlined with hepatitis C, because the long-term complications are similar in that it's cirrhosis and hepatocellular carcinoma. And so you use a similar array of standard laboratory markers as I outlined for hepatitis C, and the elastography, again, has revolutionized the way we follow these people. For those that have hepatitis B, hepatitis C co-infection, particularly in those that have carriage of hepatitis B, on starting DAAs for hepatitis C, they may get a hepatitis B flare and reactivation of their hepatitis B, so they need to be monitored for that when starting the DAA. And in those that are co-infected but with hepatitis B and HIV, remember, don't use regimes that only contain 3TC or FTC without tenofovir. 3TC and FTC will suppress hepatitis B, but you will develop resistance very rapidly. Hepatitis B will develop resistance to those very rapidly. So if someone is co-infected with hepatitis B, you need to include, or preferentially include, a regime that has tenofovir in it, or if that's not possible, then you need to add entecavir to the antiretroviral regime. And that's the case also if you use a regime that doesn't include any NRTIs. So regimes that include just an integrase and a protease, such as darunavir, dolutegravir, which was shown to be so effective in the DEF study. That does not cover. One of the shortcomings of that regime is that it does not provide any coverage against hepatitis B. So hepatitis D virus is uncommon in this part of the world. It's much more common in Pakistan, Iran and Turkey. And it's an interesting virus, which is an RNA virus that's defective. And it requires hepatitis B presence and co-infection to complete its life cycle. So measuring hepatitis D is only relevant in people that have chronic hepatitis B infection, because the virus is incompetent without hepatitis B. So it has a higher prevalence in men who have sex with men and people who inject drugs. And all those who have chronic hepatitis B should be screened for hepatitis D antibodies. This should be, if the antibody is positive, it ideally should be confirmed by a PCR for HCV DNA, but the issue with that is that there's no standardized approved tests for hepatitis D in terms of NAT testing, and so all the tests are in-house and have variable dependability. The serology for hepatitis D, you can measure both the antibody to hepatitis D, as I've just said, and you can measure the antigen directly, and that antigen is a structural core component of hepatitis D. In those with chronic hepatitis D infection, the IgG to the hepatitis D antigen is there at high titer, and the higher the titer, the more likely that there is ongoing HCV replication. Interestingly, and sort of somewhat counterintuitively, if you have replication, high levels of replication of hepatitis D, the IgM to hepatitis D is also likely to be chronically positive at high titer. And that correlates with both the level of HDV replication and also the severity of liver disease. So one of those few instances where a chronically positive IgM actually is useful. And I'll move to CMV, where a chronically positive IgM is of no utility at all because it's most often a false positive. So, as you know, CMV is most, cytomegalovirus is most commonly acquired and controlled in childhood. And the serological prevalence within adult populations ranges between 40 and 60%, but in groups such as men who have sex with men, it's much, much higher, in excess of 90%. Primary infection can occur in adults and in adolescents if they're previously seronegative, and it can happen as a co-primary infection with HIV infection. So particularly in those undergoing severe primary HIV infection that's not resolving in the normal way, think about CMV, particularly if there's a hepatic picture. In the immunocompromised patients, CMV is normally not a primary infection, but it's a recrudescence of this of the latent form of this herpes virus. And most commonly, the recrudescence occurs in late-stage infection when patients are off therapy and have CD4 cells less than 100 per microliter. The CMV antibody tests are usually CMV lysate based, so which is interesting in this age of recombinant proteins. They are occasionally based on recombinant CMV antigen, but most commonly, such as the architect, is based on CMV lysate. As I just said, the IgM assay is very unreliable and there's often prolonged false positive. In terms of primary infection, it can be diagnosed by a four-fold rise in titer of the IgG, but IgG remains positive once you've been infected, and it's very important, I think, to assess early when you've made a new diagnosis of HIV, so that you know whether someone is CMV positive or not, and therefore likely, if they come off therapy or have progressive disease, to have recrudescence of that infection. In terms of the nucleic acid nucleic acid testing, you measure CMV DNA, and that its presence in peripheral blood indicates reactivation of latent infection. Low level can occur normally, and you should watch that, particularly if there is no evidence of end organ disease. If it's high level, you need to think about therapy, but you need to understand what the clinical manifestations are. And you can use CMV DNA to determine whether you treat someone in a clinical context, but also use it to look at response to therapy. And resistance can occur, and the loss of thymidine kinase is the most common form of resistance. And so prolonged high-level CMV DNA on therapy with something like ganciclovir, you need to think about resistance. So there are a range of CMV DNA assays that all have a large dynamic range, ranging from 50 to 100 international units per mil up to more than 1 million. And a couple of those are listed there. There's the usual suspects. There's COBAS, there's ARTIS, Real-Time, Alinity, Aptima as some of those high-quality tests. They all measure different genes based on different genes. And some of them measure the polymerase, some of them measure early genes, some of them measure those genes there, UL34 and 80.5. And so, and they also use, some use whole blood and some use plasma. And remember that the viral load in a whole blood estimate is about 10 times higher than in plasma. So if you're measuring, if you've got a result from one of these tests in a patient and you want to follow them, you need to follow the same test, because the viral load results from different tests are not comparable. And so you should get the test done from the same laboratory with the same test if you're following patients long term. So when do you do CMV DNA assays? Well, you'd use it to screen disease activity in those with symptoms consistent with CMV reactivation and disease. In HIV, the most common manifestations are CMV retinitis, which is a hemorrhagic retinitis, which can cause blindness if left untreated. CMV colitis, which is painful colitis. You can get CMV proctitis and perianal ulceration. You can get spinal cord disease and/or encephalitis. And the DNA result in those patients will be positive in CSF as well as in plasma, and you can get CMV pneumonitis. CMV pneumonitis is much less common in people with HIV than in people who are post-bone marrow transplant, where that's a major complication of CMV reactivation. And so you can use the CMV DNA to point you towards one of these diagnoses, which then needs to be confirmed on characteristic changes in the eyes or characteristic changes on biopsy of the colon, or characteristic changes with inclusion bodies on BAL for the pneumonitis, as well as in situ detection of viral nucleic acid. So these assays are very useful in terms of monitoring response to therapy. You look for a reduction in CMV viral load after starting ganciclovir or valganciclovir, or in those that can't tolerate those, or resistant disease foscarnet. Iris can be problematical in late-stage patients, and CMV iris can send you blind, and so knowing that you've got a decreasing CMV viral load before starting antiretroviral therapy in someone with CMV retinitis is very reassuring. It also allows you to monitor for recrudescence after you've stopped maintenance therapy when people have immune reconstituted on antiretroviral therapy. There are also a range of T-cell assays that are becoming available for the measurement of CMV. You can measure the response to, you can measure interferon gamma responses by ELISpot or by quantiferon. you can use proliferation assays, or you can use an AIM type assay where you use surface detection of upregulation of molecules on CD4, such as CD134 and CD25, as shown here. Is that showing up? So this is upregulation of CD134 and 25 to SEB, to CMV, and then to HPV proteins. HPV proteins. And you can use a similar assay measuring CD137 and CD69 upregulation on CD8 T cells. So you can use this to determine whether people have sufficient T cell responses for CMV control, and this is most often being used post-bone marrow transplant when people are on suppressive therapy, when they've been CMV negative and receive a CMV positive donor. And this is currently being assessed at St Vincent's and elsewhere. At least using the AIM assay, it's a very easy assay to set up on flow cytometry. It uses peripheral whole blood and 4-color flow cytometry. It's very similar to an assay that I've talked about at this meeting before to detect latent TB, and it may be useful in timing the withdrawal of CMV prophylaxis post-bone marrow transplantation. Toxoplasmosis. Again, this is an infection that often is acquired and then controlled, and in HIV causes a problem in people with late-stage untreated disease with CD4 counts less than 100. And the most common manifestation is cerebral abscess, but you can have extracerebral manifestations. But in almost all those people who have extracerebral manifestations, you need to look for cerebral disease because it may be asymptomatic at the time, but almost everybody that has extracerebral disease has cerebral disease as well. And the differential diagnosis is cerebral lymphoma. And so the serology is usually determined by ELISA or IFA. And you can measure both IgM and IgG antibodies. The IgG has a very good sensitivity and specificity, as shown there. Primary toxoplasmosis, again, can be diagnosed with serology, but again, you need the IgM may be a false positive, and so you want to see the evolution of IgG and a 4-fold rise in IgG antibody to make the definitive diagnosis. And false positive IgMs to toxo are very relatively common and may be due to the presence of rheumatoid factor, antinuclear antibodies, or non-specific binding, FC binding of the antibodies in the in vitro assay. As I said, in HIV, primary infection is rare, and the disease is usually caused by recrudescence of previously acquired infection, and it presents most commonly as cerebral abscess or abscesses. And as I said, extracerebral toxoplasmosis is much less common. And so screening for IgG, again, for toxoplasmosis when you first see these patients is very important, because if they're IgG negative, they're really unlikely to get toxoplasmosis abscess. If they're IgG positive, then they're at risk of that infection. When it presents as one or more ring-enhancing mass lesions in the brain, and MRI is usually better than contrast CT in detecting these. This is what they look like. This is actually quite peripheral. They often can occur in the basal ganglia and are often multiple. But you can see this ring-enhancing abscess here with edema surrounding it. So PCR for toxoplasmosis is not widely used, and it's not particularly useful. You can confirm the diagnosis with brain biopsy, if there's, particularly if there's an equivocal response to therapy, but normally in someone that's IgG positive for toxo, what we do is we often treat them with definitive treatment for toxo, and if they're not getting better, then do a biopsy to confirm the diagnosis. And on the biopsy, you can see the organisms themselves, and in recrudescent infection, these are most often cysts, which are circular in shape. And finally, I'm going to deal quickly with cryptococcal infection. Remember, there are two species of this now that cause disease, Neoformans and Gattii, and the latter is more likely to cause lung disease than the Neoformans. And again, in HIV, this presents in late disease, untreated, with CD4 cells less than 100. The detection really still is best done by cryptococcal antigen. There's a range of these tests. They're all simple to do, and they detect both species very well. So these are either latex agglutination or ELISA type methods. They're highly specific, and they can be done on either serum or CSF, and the main manifestation of cryptococcus that we worry about is meningitis, and CSF has a higher sensitivity for antigen in those with meningitis. So the serum antigen sensitivity in people with cryptococcal meningitis ranges from 94 to 100% in serum and 90% for lung disease. Whereas in CSF, the sensitivity is between 87 and 100%, and the specificity is 100% in CNS disease. Lateral flows are available, and so these can be used as point of care, and you can see there that they have good sensitivity in both serum, CSF, and reasonable sensitivity in urine. The specificity, as I said, is very good. The issue with the lateral flow assays is that they're semi-quantitative at best, and they're relatively, and their quantitation is relatively poorly validated, but they're cheap. But you know, when we treat people, we want to see a decrease in the antigen, and so the lateral flow assays are less ideal for that. The other mechanism for this is measuring, is identifying the organisms under the microscope using India ink. And when we treat these this infection with antibiotics, we're looking for a reduction in antigen. And again, the reduction in antigen is important in terms of timing the antiretroviral therapy, because one of the irises that will kill you is cryptococcal meningitis iris, because it can cause blockage to the flow of the CSF, hydrocephalus, and death through that. And often those people require shunts. You're looking for a decrease in antigen, but remember the antigen can persist for many, many years. And so these people can reconstitute. They get on antiretroviral therapy, they can get quite a high CD4 count, low viral load or undetectable viral load with a low level cryptococcal antigen. And that shouldn't stop you stopping the maintenance therapy if that low level titer is maintained for a significant period of time after they've immune reconstituted and have sustained viral load and they're compliant. But obviously when you take them off the suppressive anti-cryptococcal therapy, usually an azole, you need to watch them carefully and monitor the antigen for recrudescence. But presence of the antigen at that stage doesn't necessarily mean that they've got ongoing infection. If you wanted to distinguish between Neoformans and Gattii, as I said, the antigen test does that very well. PCR doesn't do that well. Things like film array don't really add much to antigen. So in a study we did in Yangon in people with encephalitis and meningitis using the film array, we saw no more diagnoses of we didn't add any new diagnoses of cryptococcal using the film array on top of the antigen. And that was in a large sample size of well-characterized patients, over 500 patients with encephalitis. And if you want to distinguish the species, you either need to use culture, in particular culture mediums, or you can use mass spectrometry. So I think it's interesting that, in the 21st century, nucleic acid testing is really important, but it hasn't supplanted serology. And the increasing lower limits of detection of protein-based assays are often providing cheaper alternatives for direct detection of pathogens. And so these may provide more sustainable alternatives in resource-poor settings and for disseminated models of care where centralised systems are not ideal to access isolated populations. And there's increasing options for point of care based on both NAT and serology testing. And I'll leave it there. Thanks very much.
Well, thank you so much for very informative presentation from Tony. So I think I'm sure that you have questions for Tony, but we will keep at the panel discussion at the end. So right now we have time for coffee break. So we have break for 15 minutes and then we come back to listen to the next speaker. Thank you so much, Tony. Okay. Yeah, let's have coffee break first.